So we are going to hear this few very eminent speakers. We have one problem sometimes we face, but there are multiple ways to handle it. And we have excellent speakers, so they will share their ways, how they have handled it. We have Dr. Rajiv Chaudhary for Indore. We have Dr. Harbans Lal, incoming Vice President. We have Dr. Mohan Rajan, he will be joining very soon. Dr. Saumil Kothari from Mumbai, and Dr. Sahil Vashavda. And at the end, I am here. See, the brief outline of the program, as everybody knows, we have very important. We have important complications. And for the first faculty, it will be presentation of 2.30 minutes, 2.5 minutes, and then next two will their share way of methods for about 1 and 30 minutes. So we go ahead, and we go to the next presentation. Okay. See, my first is how do we manage intraoperative small pupil? So you can see that the axis has been done. The lens is, the cataract is rotated, and you can see that the pupil is getting smaller and smaller. I already started phaco, but then you can see that, oh, very small. Now my choice of expansion is capsule care, because the capsule care, though it does not retract the pupil up to the limbus iris, but then it retracts the pupil, the iris at the same level, so you don't traumatize the iris too much during insertion of the lens, the insertion of the instruments, etc. Again, you can see that the pupil is enough dilated, and the phacoemulsification is done without any problem. You can see that this cracking is done. Now the lens nucleus, the fragments have been chopped, and now it is being emulsified. So it's easy. The pupil remains large and enough, so that you can see that the lens is emulsified, and then you can see that the cortex is being here. Normally, if the cortex is too thick, then I will use coaxial. Otherwise, bimanual technique is good. And you can see here, the capsule margin has been released from the capsule care, but it will stay still safe, and there is no trauma to the capsule margin. You can see that. And once it is done, the visco is put. See, now it is easy. It's easy. You can see that. But at times, what I've seen, if you pull it too much, then the capsule margin can give a tear at that particular point. And then once it is done, you can put the lens, and you can rotate, and then the visco is removed after removal of the capsule care. So this is my way of handling. Now I will request Dr. Sahil Vasavda. Please go ahead.
Sir, you need to stop screen sharing.
That is it.
Yes, sir.
Okay. Okay.
So thank you very much. That was a wonderful presentation. We do receive research grant support from Malcon Laboratories, but has no relevance to this presentation. So this is a typical standard case. This happens to be a femto, but it could be even otherwise, where the pupil is right from the beginning not very well dilated, but not small enough for you to start off with iris retractors. And quite often what happens is that while removing many of these fragments, sometimes some of these fragments tend to hit the iris. Like you saw there, it's rubbing the iris at the two different spots if they are larger fragments, and then that stimulates the iris, and therefore the pupil starts coming down smaller and smaller. So it's not as if you cannot go ahead with phacoemulsification in such a situation. You can go ahead and remove the lens, but cortex removal can be a challenge in such situations, because if you go ahead with this pupil in the experienced hands, you can get away, but quite often you end up catching the iris more and more inflammation, more pigment release. And therefore I find the use, of intracameral use of diluted preservative-free adrenaline, 1 in 5,000 dilution. The moment you inject it, if the pupil is otherwise a mobile pupil and not a fixed and rigid pupil, you will find that it will slowly but surely open up, and it opens up sufficiently that you are able to go ahead and complete the rest of the surgery like you can see here. Now this pupil is large enough that I'm not so much worried about catching the iris or doing other things along with it. And it remains so if the iris is then not manipulated, it remains so through the end of the surgery. Like in this case, we are even able to align the toric IOL to the position. This is another case where during fragment removal, I found it very challenging. The pupil came down heavily on me, but it was initially a good pupil to start off with. And the pupils which are initially good to start off with and where there is no iris trauma or prolapse, they respond very well to this diluted adrenaline. And you can notice here, even at the end, the pupil remains in size for lens removal. Another interesting use is after IOL implantation. So this is a trifocal toric IOL, and we want to make sure that the toricity alignment is not hampered by any which ways. So we want to make sure that the dots on both sides are aligned. And you can stretch the pupil and see, but you are never sure about that. So even after IOL injection, you can inject a diluted preservative-free adrenaline, and now this becomes easy, and you can make sure you remove the viscoelastic completely, as well as make sure that the IOL is in perfectly placed at the end of surgery. So this is something that I find quite useful. I'm sure there are better tricks as well to do it.
Yeah.
Thank you so much.
Thank you, Dr. Shane. Now I request Dr. Rajiv Chaudhary to share his views. How does he manage intraoperative small pupil? Dr. Rajiv. Meanwhile, Dr. Harbans, do you have a word to say? How do you manage intraoperative small pupil? Okay. Raju, you are not audible.
I think maybe this the adrenaline works better in a laser treated patients where there is a chemical mydriasis more common because of the laser, as compared to when you are doing a routine phaco surgery where there may be more trauma. In those cases, this diluted adrenaline probably doesn't work as well as in these cases where people got nearly fully dilated.
Okay,
so
Raju.
once in between, if you get a constriction,
Yes.
so probably initially best way is to try diluted adrenaline, as Shell has explained, but sometimes it may not dilate as much as you require. And if you are hesitant and there is a dark brown cataract, probably at that time with the you require the dilatation much more as compared to the soft cataract, which you can manage with the small pupil, as Shell mentioned. If you have the toric lens, then so another option is to use visco iris soap, inject the visco behind the iris so that you should not accidentally capture the video is not precision.
ये हॉल में गड़बड़ हो रहा है, तुम्हारे हॉल में गड़बड़ नहीं था।
हाँ, वहां तो बढ़िया चल रहा है।
बिल्कुल अच्छा चला। अरे भाई, हॉल इंचार्ज, डॉक्टर हॉल इंचार्ज, प्लीज, what is going on?
Sorry. Damn it. The video is not playing.
सर आपकी स्क्रीन पे दिख रहा है, प्ले हो रहा है?
No, not playing here also.
It's not playing. We can see the screen, but it's not playing.
ये उस पे आपके एंट्री कुछ दिक्कत है सर, या तो बैंडविड्थ का कुछ इशू है?
No, bandwidth is good.
So meanwhile, I would just like to say that we can, in a small pupil case, we may choose to continue with phacoemulsification using low flow parameters.
Yeah.
Another thing is Malvin ring
Really?
works very well. Malvin ring works very well. If the case is really tough and a lot of phaco is remaining, I think use of the Malvin ring is very, very useful, or Bhattacharya ring is very, very useful.
Even at this stage also you can use Mulligan ring or any other pupil expanders.
My preferred choice is always Malvin ring in all cases.
Thank you.
To start with our in the middle of the things.
Thank you. Rajiv, go ahead.
Yeah. Yes, sir. 1 minute. So, sorry for the inconvenience. So it was the mild dilated pupil. We did then try to inject the adrenaline, but still because of the some trauma, it go on constricting. So we try to use the high risk hook at this stage. And main important thing that you have to separate that iris from the capsular axis margin. That is the only important thing you have to take care. Once you may use 3 or 4 as per the requirement. I use 4 in this. And once you are done, you can finish your surgery, and whether it is toric, and you can perform well. So you should not hesitate, because sometimes in the mid dilated or small people, we try to do the phaco, thinking that we will be able to manage, and we may end up with the trauma to the iris and posterior capsule, and there might be some retained cortical material behind the iris. So you should use a good dilated pupil, whatever way you can do. Thank you.
Thank you, Rajiv. Now you continue with your next presentation. We are going for the rexis extension, and how do you manage rexis extension?
There are 2 videos I am going to show on this.
Please do that.
This is a hypermature cataract. Usually nowadays we get extension only in the hypermature cataract, most probably out the. This is a small with used staining. I am using the viscot or high specific gravity. You can see that we are going to length, and there is a slight extension. We try to inject the visco more, and there is an extension of the rexis here. So we try to cut that portion of the rexis and convert it the complete. Now, important step here is now the next step. You should either you do the supracapsular phaco, or should not give a much strain on the bag granules, because there is an extension of this rexis, and you may end up with the tear, posterior capsular tear. So you should be gentle, careful, should not give stress. And if you feel adequate, you can do the supracapsular phaco, gentle. You should not stretch much more here, and bring one of the portion here. This is another case. Same. It is same. This extension that.
I think you are showing the same video.
Yeah. This is another case which pressure is there. You can notice that fluctuation of the chamber. It is extending here at this point. Re-injecting. You can see that slight extension is there. It is up to the granular. So you may convert it into the full capsular axis. You can see that the extension is visible.
Yes.
So just with the gentle and straight pressure to the center, you can convert it into the
large
rexis. However, that one portion is gone beyond the granular adhesion margin. And you can deliver this pieces into the anterior chamber and without giving stress. The important thing is that in this case, you have to give minimum stress to the granules. So it should not be there is extension of the tear. And put the intraocular lens in the back. Thank you.
Thank you very much, Rajiv. Now, Shail, would you like to request you to share your views, your way of managing the extension?
So I think one thing we need to make sure whether the extension is up to the equator or not. So this is something that was noted at the end of irrigation aspiration, where you can notice that an extension has been noted in the sub-incisional area. First thing you want to make sure to prevent this extension is to inject dispersive viscoelastic, which will act as a tamponade, and there is no sudden shallowing, and then inject cohesive viscoelastic and look for how far it has extended. Like in this case, we realized when on stretching the pupil, we found that this has still not gone up to the equator. So it is still reachable, it's still not extended up to the equator. And when this is the case, you still have an opportunity to convert it and bring it back. And this is the time you want to use forceps and use it from the smaller incisions, not from the main incisions, to prevent leakage, and pull it to centripetally and up. So pull it towards the center and pull it up. That will create good vector forces to bring the capsulorhexis inside. And now this will act as a normal capsulorhexis. It's just that it has ended up being a little bit more large. So there will be less rhexis cover. If you can notice, it's been completed here. This is another case of a young lady. So generally young patients are the toughest to operate. And you can notice here that the patient is looking in all different directions. Centration is an issue with the surgeon because the eye is moving very nasally in spite of all possible sedation and all possible things being given to the patient. And slowly but surely, when this happens, the chamber tends to shallow. And notice here that the patient is uprolling the eye tremendously. The surgeon is trying to bring back the rhexis, but he feels that this is probably going out of hand. So what he does is the correct thing, that is to try and make sure that, we do something else. We try and inject viscoelastic to try and bring it out. And at this point of time, it was decided to stop proceeding further to try and salvage this rhexis. And this was to our surprise that in spite of this being not an intumescent cataract, just a normal cataract, it absolutely split for no good or bad reason. So now the thing to make sure is that once this has split, what do you do next? You've not even started phacoemulsification. So the trick is not to inject heavy cohesive viscoelastic in the open area, because that may split it further and make sure that it goes beyond the posterior capsule. Create a nick on the opposite side and try and convert it as much as possible up to the split area, so that there is at least a 3/4 of a reasonably good size rhexis. Otherwise, this rhexis was too small on this side to consider safe phacoemulsification. Once this is done, it allows reasonable strength and the salvage from the opposite side. You need hydrodissection, but be gentle because you don't want too much of excessive flow. And similarly, you want to be gentle with your parameters. So here we are using an IOP of 20, which is an equivalent to a bottle height of 40. So you have to maintain a balance of not being too fast and too aggressive with your parameters. So whatever your normal parameters are, drop it by 20-30%. And use a lower flow rate. So things will happen slowly with the lower flow rate, but at least it will make sure that things are happening under your control, and stay as much central to the area and avoid going or making sure that there is no turbulence towards the area of the split rhexis. And having following these principles, make sure that you don't let the chamber shallow at any point of time, even when you changed hands between irrigation aspiration, between the two, inject dispersive viscoelastic. So do all of these steps to try and make sure that this tear doesn't extend up to the equator, and you can still go ahead and consider in the bag IOL implantation in such a situation. Thank you so much.
Thank you, Dr. Shail. Now, Dr. Saumil.
Hi, yeah, I'm audible now. So
Yeah.
I'll be sharing two quick videos about, one is about how to prevent rexus extension if it's already going outwards, and the second one is what to do if it is already extended. So here you see that the surgeon is actually going ahead with the rexus, but at some point of time it is tending to extend out into the periphery at this point. What is important is you not only centripetally, you try to sort of back pull on the rexus margin so as to get the rexus back in its shape. So the direction of pull is not only in the center, but towards or backwards from the direction of propagation of the rexus. So this is one video. The other video is about if there is already a rexus extension, like out here, you see that it's already extended because of the intumescent cataract. You do just place a nick with micro scissors and go ahead and make a semblance of a rexus as best as possible, so that you can continue with the phacoemulsification. So here we have nicked it on the superior side, and then on the inferior side we are also creating a semblance of a rexus. Right, sir?
Thank you. Dr. Somil, you continue with the next complication, zonular dialysis.
Yes, I will go ahead with that.
Meanwhile, Doctor, if you have 1 minute, Dr. Harbanslal, how do you manage extension? Is there something new and different?
I think sir is on the phone.
Sir is on the phone, I think. Yeah.
Okay, fine. Okay, Somil, go ahead, please.
Yes, sir. So this is a case of a subluxated cataract, and it's not very dense. It's not very. It's like the NS2 category, and here we use the Varion system. What is important out here, just the important steps, I'll just take you through the subluxated as cataract or a zonular dialysis. You plug the gap with viscoelastic, that is a dispersive viscoelastic. You do stain the capsule and go ahead. Here we are creating a Hoffman pocket, that is at the point of maximum subluxation. You create a subscleral pocket, intrascleral pocket rather. You go ahead and do an LRI, sort of a nick in the peripheral cornea, and you dissect it with your crescent from the corneal side into the scleral side. So it's like creating an SICS pocket, but instead of normally we are used to going from the sclera to the cornea, this is a back pocket created from the cornea to the sclera. Then with the incision, the rexus is the most important part. You direct your forces towards the area of maximum subluxation, so that not to create more or aggravate the subluxated cataract. Aim for a smaller rexus. Don't aim for too larger rexus. Of course, you should not aim for too smaller rexus also. See that the rexus is centered on the cataract and not on the globe as such, because remember the whole cataract is subluxated. So the rexus should be set on that. After the rexus creation, you go ahead with your iris hooks. So here we are going ahead with a couple of iris hooks just to stabilize the bag vertically. You go ahead with implanting a CTR or a capsular stabilizing device also. This will stretch out the capsule horizontally. So with the iris hooks, you have vertical stability. With the CTR, you have a horizontal stability. This makes your bag quite stable. You go ahead with the low flow parameters with your phaco. For irrigation aspiration, you use a tangential direction of aspiration of the removal of cortex, because it may be difficult to pull out the cortex centripetally, right, radially rather. So you use tangential forces to remove the cortex. Now I'm just optimizing this rexus size in this particular case. Now having an optimized rexus, you go ahead with the scleral fixation of the bag. And in this case, we are using the Emmett's capsular tension segment. And we are going through the Hoffman pocket and railroading a 9-0 or 10-0 proline suture. You can also use Gore-Tex. You can use, there are other suture materials available. And this is a double armed. So you insert the other arm of the double arm suture through the pocket again. So all you create is 2 puncture wounds through the pocket. You retrieve the sutures through the LRI incision that you made, the corneal incision, and you tie it together. So tying it really creates the knot, and the knot is buried deep into the Hoffman pocket itself. So it's a very neat surgery. You don't have to do any conjunctival dissection. So out here, because everything went off well, we had planned for a toric lens. So we are centering the lens according to the varion and its axis. And after the axis is optimized, we remove the OVD, and that's practically the end of the case. So this is 2 hours post-op day 1. You can see the Hoffman pocket is very neat. So this is the 4th day post-op, very clear cornea and good eye. Thank you so much.
Thank you, Paumil. Rajiv, can you go ahead with your way of managing this complication?
This is a case of subluxated cataract, probably 2 to 3 o'clock hours, and probably this type of X-ray, ideally you can use the ring, but I have tried to use that without ring segment, and tried to put the intraocular lens at that angle. Do the axis away from the away from the area of general dialysis. Use good viscoelastic at this area where the dialysis is there. So about minimum stretch, and you may try to do the spiral axis in these cases. So you will end up gentle hydrodissection. Low power phaco, low bottle height. So avoid and good viscoelastic in between, so that turbulence is much less inside the eye, less stretch, and try to dislodge this nucleus into the antechamber, and then you can do the supracapsular phaco. So there is a minimum stress on the zonules, and once you not increase the trauma to that, you can put the intraocular lens in the direction of the jonular dialysis, this 3-phase, and you can, and this will act as your ring. Yes. Thank you.
Thank you, Dr. Rajiv. Now can we have Dr. Harbans Lal? Sir, how do you manage zonular dialysis?
So this is entirely.
Well, doctors, sorry to interrupt, but with all due respect,
just reverse of what Rajiv has shown.
Just a reminder.
Yeah. Can you see this is a small journal dialysis on this side? After completing the surgery, I found there's a small straight line. But I now personally feel any journal weakness or dialysis has to be taken care of with the increasing use of multifocal IOLs, aspheric IOLs, and toric IOLs. Because even a 0.5 millimeter of decentration may cause a lot of problems to the patient. So I put on a CTR ring even if I got any doubt of any jonulopathy in most of my patients. Thank you.
Thank you very much.
Saved your time.
Thank you.
Harbans has the second presentation.
Harbans, okay. Continue. How do you manage PCR?
So so this is the now hard cataract operating at a very high vacuum, and I removed the chopper, but still it was being performed in the periphery, and you can see that there is a cut taking place over there.
So can you make it full screen, please?
Yeah.
Thank you.
So this is I removed the chopper because the vacuum setting was 600. And you can see that I pulled and it was not being performed in the central safe zone. That was a mistake. So then I tried to lift it up because it is sub-incisional, and you can see that my with the sphere gets enlarged further when I try to lift it up. And now I inject the viscoelastic. I thought it is soft, and while viscoelastic should not be injected so much that it pressurizes the eyeball, the tear really gets fully extended up to the end to end. I have got no choice but to bring it out of the rexus and out of the capsule of cornices and collapse into the anterior chamber in front of the iris to be safely removed. Once I achieve that, now I'm just lifting it up and make sure that it does not drop down. And slowly it comes to the anterior chamber. And I use my own technique of removal. I do not prefer doing the phacoemulsification in presence of the PCR most of the time. So I enlarge the incision to nearly 4 millimeter or so, 3.5 to 4 millimeter in these cases. So once the incision is enlarged, I will use my technique of chopstick technique, which I have published in JCRS long time back. So then I take the two instruments, one chopper and one any other chopped instrument, and then try to embed it and try to pull it out. The advantage of this is that the chamber depth is maintained throughout. These are the least bulky. There is no fluid which is going inside. So most of the time, if there is no vitreous in the AC, you can prevent the vitreous collapsing into the AC. Slowly and slowly, I really mechanically keep on crushing and take it out. And if we enlarge the incision a little bigger than this, maybe 5 millimeter or so, this can be taken out in one piece. So once this most of it has been removed, and I thought it's not coming out so nicely by this technique, and I didn't want to further crush it and the smaller pieces may drop down. So now I go for the Iodine Scaffold. I release the IOL in front of the iris and then guide it back into the behind the iris. And in this case, some amount of viscoelastic you must inject between the anterior capsule and the iris so that it can be guided very comfortably. And then we dial the another loop in. Now with that scaffold available, this lens is more or less secured and nucleus is not going to drop down. So still I do not perform the phacoemulsification. I use again my same technique of removing it mechanically. So this way there is no hydration of the vitreous whatsoever. Now instead of taking a regular irrigation aspiration, I take the vitrectomy cutter. If by any chance any vitreous is there, that can be cut. But luckily in this case, there was no vitreous and we removed the clot which was there. We removed the viscoelastic and everything, the remaining cortical fiber, and the chamber should not be allowed to collapse under any circumstances anytime. So chamber depth is maintained. So before I remove the irrigation port, I inject the air from the another port to maintain the chamber depth. In spite of no sign of vitreous present, still at the end of the surgery, we will constrict the pupil and put the tricot and check whether there is any, and we did the optic capture in this case to be 100% sure. The optic capture has been achieved. Air has been injected to maintain the chamber depth and to be doubly sure that we injected the tricot and washed it out to ensure that there is no vitreous and chamber was well sealed. Thank you.
Thank you, Dr. Bansal. Shail again. Dr. Shail, how do you manage?
Yes, sir. I'm ready. Once sir stop sharing, I can share.
Yeah, please.
Sir,
Urban, stop sharing.
Okay.
Urban, stop sharing.
So this is the situation in the beginning. I mean, hardly midway through the surgery, 3/4 of the nucleus is remaining, and you have this large PCR that has already been, created. So the first thing that we need to keep in mind is that whenever we need to first find out whether there is vitreous present or not, and if there is vitreous present, we need to address it before moving forward to any further step of surgery. So the best way to identify vitreous is to inject triamcinolone, and we did find vitreous already prolapsed in the chamber, and therefore it needs to be addressed. Now we prefer doing a vitrectomy through the pars plana approach, and I'll come to why we prefer that. You need not necessarily need a trocar for that. And notice how through this PCR, the vitreous gets sucked in. It gets pulled down beautifully so that will make sure that there isn't much traction or pull on the vitreous that is occurring because it's being removed from where it's coming out. And therefore, you can free this entire area of vitreous, and then you remove surrounding areas of vitreous pockets as well. With limbal vitrectomy, what happens is that we are using a top-down approach. That is, we are dragging more and more bulk of the vitreous up, and therefore there are chances of the posterior capsular rupture increasing in size from what it was initially, compared to the pars plana, where we are actually draining it from where it is coming, and therefore you not only get a more symmetrical vitreous removal, but also lesser chances of the existing tear being removed. And once you have done adequate vitrectomy, you can go ahead as if there is nothing happening. Of course, you make sure that you use lower parameters and use lesser flow rates so that the tear doesn't extend and there is no drop of the nucleus. But you can go ahead even with phacoemulsification and remove the nucleus like we could in this case. And at the end of surgery, always, like Dr. Bansal sir correctly showed, make sure that there is no vitreous disturbed during IOL insertion and such techniques. And this is another video to show a normal in the bag IOL implantation, but somehow there was some vitreous that had prolapsed in the chamber through some defective or weak zonules. There was no zonular dialysis, there was no CTR, nothing that was used. And notice this triamcinolone vitreous in the anterior chamber. And once the trocar is done, notice how this vitreous from the anterior chamber will very nicely get sucked in through those pre-existing deficient zonules, and there it goes. So you maintain the IOL in the bag, you maintain the bag stability, and you can go ahead with the bag. Thank you so much for the patience.
Thank you, Shahid. Now, whether Dr. Mohan Rajan is joined, I don't think so.
Yeah, I'm joined.
Oh, good. Thank you, sir.
Yes, sir.
To share your way of management of PCR, please.
You want me to talk now, sir?
Yes. How do you manage PCR?
Yes, sir. I will share my screen, sir.
Please.
You able to see my screen?
Yes.
Let me thank Dr. Ashok for this wonderful opportunity. It's always a pleasure to be in his course because his course is quite different. And congratulations, Dr. Arban Shalal, for the wonderful victory. Thank you very much, sir. And I'm just going to show you one posterior polar cataract here. You can see here, this is a posterior polar cataract. Aim for a rhexis which is not very big, not very small. Make it probably around 5 millimeter. Just in case there is a PCR, you can always do an optic capture. Do not do a hydrodissection. Just do a hydrodelineation. And do not try to rotate the nucleus. And I'm trying to do what is called something like a slow motion phaco. This is a fairly, not a very hard cataract fortunately for us. Most of the posterior polar cataracts is not very, very hard, but this is about grade 2 cataract. And you can see here, I'm trying to remove the last bit. You can see what is happening underneath. There is a huge tear in the posterior capsule. Okay. So I don't pull out the eye, pull out the phaco probe. I always inject viscoat into the anterior chamber, then immediately go in for the preservative-free tricot. I do the bimanual anterior vitrectomy. You can do the anterior vitrectomy either from the front or from the back, as Shail was mentioning. Always remove the vitreous first and then remove the cortex on the epinucleus. Don't try to remove the vitreous, try to remove the cortex in the presence of the vitreous, because that will produce traction on the vitreous base and also produce detachment of the retina and future retinal problems as well. So always try to remove the vitreous, and that is what I have done here. You can see typical, there are two pillars of the posterior capsule, which is very, very typical of the posterior polar cataract. And always I put a multi-piece lens. What I do is, because this tear is a little bit huge, very difficult to convert this into a posterior capsular rhexis, I always put the lens, a multi-piece lens, preferably an MA60 lens or a sensor acrylic lens, whatever is available to you, and try to put the lens. I do what is called the drop-in technique, or with the McPherson forceps, making sure that the haptic goes into the sulcus very nicely. I don't dilate, because if it dilates, there's a possibility of going back. So always I do use a McPherson and drop it into the sulcus, and that is what I do. Then what I do is, I don't leave it in the sulcus there. Then I do what is called the optic capture. You can see this optic capture is very, very important. And again, you can see this optic capture is the way wherein you can make sure the long-term stability of the lens is there.
and preventing UGH syndrome and making sure the lens is as close to the bag as possible. Now, that is the advantage of this optic capture. You can see here, I am doing the optic capture, putting the lens is very good. For this, you need a fairly good size rexes. If you have a 6 millimeter rex, it's very difficult to do an optic capture. That is why go for a 5 millimeter rexes in a posterior polar cataract. But just in case you have a problem like this, you can always do the optic capture. You can see here this optic capture. The end point of the optic capture is the ovalization of the anterior capsule. The ovalization of the anterior capsule shows that the optic capture is complete, and of course you have removed already the vitreous. The pylocar is the myocol is put into the anterior chamber. What I do is I always make sure that I suture all the wounds when I have a PCR, because the incidence of endophthalmitis is one thing which I always, because we can always remove the sutures later, but the incidence of endophthalmitis, if you have a leaky wound or a micro leak in the wound, is as high as 4 to 5 times when you have a PCR and the vitreous loss. You can see the optic capture 2 months, 4 months, and 2 years after the surgery. And just to show you the another case, you can see here, I'm trying to do a epinucleus removal. This again another patient, posterior polar cataract. This is what I want to give as a take-home message. Inject viscoat. Again, don't have any financial interest. Inject viscoat and come out of the eye, stabilize the eye, immediately inject preservative-free tricot, remove the vitreous, and then remove the epinucleus and the cortex. And then you can go ahead and do the optic capture or whatever it is you want to. Thank you very much for the wonderful opportunity, Ashok.
Thank you.
Stop sharing.
Mohan, please continue. Suppose the nucleus drops in the vitreous. How do you manage?
Oh, you want me to continue? I'm sorry, sir.
Yeah, that is the next complication.
Yes, yes, sir. Just give me a minute, sir.
And then we have Dr. Rajiv Chaudhary. Sir, be ready.
I am ready, sir.
It becomes very easy, no? On dias, it was so difficult physically, no? You have to stop your laptop, go get up from your chair, go to the podium. Here it is very easy, comfortable.
Sir, I'm sharing my screen again, sir. Sorry, sir.
Yes, yes, please share. Nucleus
Just
drop.
to show you a nucleus drop, sir. This is a patient with a nucleus drop, probably a posterior polar cataract, which I didn't realize. And this is another patient with a dense brown cataract, probably because of the hydro rupture. You can see as soon as my sister puts the viscoelastic on the cornea, and the nucleus disappears into the vitreous cavity. And what do? What you don't do is don't try to chase this nucleus. If you try to chase this nucleus into the vitreous cavity, and that's what many people do, and that will end up in a major problem like a giant retinal tear or a medical legal problem. You can see that the nucleus is gone inside. What I do is I clean up the anterior segment first. Okay, I clean up the anterior segment. You can see that I put an infusion cannula. This is done long time back. So nowadays we do a sutureless 23 gauge vitrectomy. Then I make the nucleus mobile. Once you make the nucleus mobile, then I use the sleeveless phaco tip, just like the fragmentome. I use the sleeveless phaco tip and bring it up. You can see I just bury. But once you have to make sure that the vitreous is completely removed, making the nucleus mobile, don't try to do it without doing a proper vitrectomy. That is very important. Then I support that nucleus because it's a fairly soft cataract, the posterior polar cataract, as I told you. Support the nucleus with the endoilluminator and go ahead and doing the phacoemulsification in the pupillary plane or in the anterior chamber. So if you have another thing here in the nucleus, whole nucleus, fairly dense brown cataract and a fairly dense nucleus going into the vitreous cavity, see how I'm doing a 3-port pars plana vitrectomy, trying to remove the vitreous. You can see the nucleus there, and the view is not very clear because the cornea was hazy in this patient. I do what is called the spear technique. The spear technique is nothing but putting a myringotomy knife into the thing and spearing it just like you spear the nucleus, you bring it up into the anterior chamber, then extend the incision and then deliver the nucleus the way you see. Nowadays you have very good fragmentos which are available and which you can fragment, but only thing is making sure the nucleus is mobile, removing all the vitreous, then use the fragmentome in the mid-vitreous cavity. Just to show you this, how it is important. If the nucleus doesn't go into the vitreous cavity, still in the anterior vitreous phase, then it can do what is called the anterior assisted levitation. This is called the anterior assisted levitation, and just like you bring it up and then deliver it, just like the way you do it and do an SSCS, and then I put an anterior chamber maintainer, then I put tricot, and obviously the vitreous, this thing is disturbed, and then I do a bimanual anterior vitrectomy, and then in this case, because the patient is very old, I put an anterior chamber IOL, and the patient did very well. Okay, again, this is another patient you can see here. This is one of my postgraduates, and she tried to do a pseudo exfoliation cataract, a total cataract, and she did a thing, tried to deliver the nucleus. The only thing is she's giving the pressure and the counter pressure at the wrong direction. Okay, if you give wherever she's giving, we have to give the counter pressure, she's giving the pressure, and wherever she's giving the pressure, she's giving the counter pressure. And you can see that, and the nucleus starts sinking. But the nucleus has not gone into the vitreous cavity. It's still in the pupillary area. Either you can do anterior assisted, or you can go through the pars plana, which is called the posterior assisted levitation. Measure about 3.5 millimeter from the limbus and put a myringotomy knife and put a second instrument and try to bring the nucleus up. Okay, that's what I'm trying to do. I'm trying to bring the nucleus up. This is called the posterior assisted levitation of the nucleus. But this is only for very old patients. Don't do it in young patients. Don't do it in high myopes, because you are going through the vitreous base and there's a possibility. All these patients of nucleus drop, PCR, it's important that you have a meticulous follow-up postoperatively, dilate and have a look every visit. Look at with an indirect ophthalmoscope, look at the retinal periphery, and you can see here in this particular case, I was able to deliver the nucleus without any problem. And after 2 or 3 months, I did a glued IOL for this particular patient. So this is as far as the nucleus drop is concerned, sir.
Thank you, sir. Thank you. Dr. Rajiv?
Yes, sir.
I'll stop sharing my screen, sir.
Yes. આપણે કરશે આપણે કીધી જવાનું છે શેરમાં નીચે જવાનું સીધું સ્ક્રીન કરવાનું લાવી જશે ને હા
So this is a case of a hypermature cataract. Why we are doing the plexus with the slight pressure that you feel, and with the gentle pressure that it is gone. So now the option is to nothing else. It is in mid vitreous to the pars plana vitrectomy. We use sutureless infusion and illumination, good vitrectomy. There was indentation from the side, separating the vitreous from the nucleus fragment. And once do the phaco fragmentation in mid vitreous cavity. Once we have done this phaco fragmentation, and for that I use a special 0-degree phaco tip, because then it gives a good hold of the nucleus and completing the fragmentation. You have to keep your infusion slightly regulated, because that fragments move fast. And once I have completed this the second option that I use always to incision and include the iris claw in this instead of using anything else, because now already there's too much trauma. So I use iris claw lenses in this type of cases. So it's very easy to include these lenses in the complicated case, like already eye is too much traumatized, and then its surgery is finished. Thank you.
Thank you, Dr. Rajiv. I would like to share my experience. How do I manage? You cannot start screen by others. Okay. 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 What's this here? Can you see my screen?
Yes, yes, visible.
Yes, sir.
Thank you, sir. So these, see, actually, what I have seen that when the nucleus drops into the vitreous after PCR, no, it's a very, very scary situation, and particularly those who are not used to it, they really get scared so much that how to manage it. So usually my advice to the beginners that always relax for a while, take a little half a glass of water, think, and then start working. Now, what I do usually that I use, as Rajiv has said, now I use the same phaco probe, but without sleeve. And as he said rightly, the bottle has to rise up because first of all, you have to do the vitrectomy. That is very important. You do the vitrectomy, clear the vitreous, and then you can, this is what you see here is the phaco probe without sleeve. And that's why, because of that, you see a lot of air bubbles coming in here in the view. But however, if you can manage, it is very good. Otherwise, another option, suppose you have a fragmentome, it is a better option. As the Rajiv said, is very important. And the fragmentation has to be done in the mid-vitreous cavity. Please don't do very close to the retina because then you are likely to injure it. So we have to bring the nucleus in the center and then do the emulsification. So this is what my way of doing it. I use the phaco probe to the same wound. I mean, they pass about 2.5 millimeter, 4 millimeter away from the limbus. It is done. Vitrectomy is done. You see that the retina is good, and you can put the lens in the sulcus, whichever support is available. So we go to the next IOL drop. How do you stop the screen? Stop share. Okay. Dr. Harbanslal.
So far as the IOL drop is concerned, actually I do nothing. I refer it to the posterior segment surgeon.
That's the best answer.
That's a clean up.
End of the presentation.
Yeah,
excellent way of managing this complication. Excellent way.
Yeah, so the simplest way. And if he needs my help for doing a good IOL or something, I'll be there. Otherwise, if he or she is comfortable doing the IOL, they go ahead.
Okay.
Thank you.
Thank you. Dr. Samit Kodari, please go ahead. Sir, we'll teach you this time. So when you go back, you will be able to do it. Excellent presentation.
Arpan, since you become the vice president, after 2 or 3 years, you have to listen to us now.
Yeah.
Okay.
Actually, I thought, what is the point of showing the borrowed videos? So I thought, let's be honest, that if you are not competent, refer to the competent person.
Being vice president, you become wiser.
Oh, my God.
Thank you.
Yes. The society is very friends now. Saumil, are you ready? Saumil?
I think Saumil has just logged out. I think there's some internet issue with him.
Oh my God.
Might be having some other talk somewhere else. So next presentation.
Okay, meanwhile, Dr. Mohan Rajan, can you go ahead?
I will show you something about the IOL, sir. That is a haptic braking. That's what you wanted, no?
No, IOL drop.
Oh, IOL drop. Okay. That you didn't mention, sir.
Then haptic. No, sir, it is already there. I sent you the program.
Okay. Okay, but I can, if you give me 2 minutes, I'll get the IOL drop. That's not
IOL drop as well as then it is followed by haptic braking. So you have 2 presentations.
So meanwhile, we can continue with the discussion. Actually,
Yes, sir. Sorry to interrupt, but the discussion should commence and we have only 25 minutes left. Just a gentle reminder.
Don't worry about it, dear.
Sir,
Yes, sir.
I will show about the IOL exchange and haptic braking, sir.
Okay.
Go ahead.
Okay.
I think like Dr. Abanslal sir correctly mentioned, Dr. Mohan Rajan sir and all of these are very well-trained posterior segment surgeons also, Dr. Chaudhary and also. For a purely anterior segment surgeon, the safest technique for a drop nucleus is like Dr. Urbanslal sir mentioned, the bye-bye technique. Just let it go, clear the vitreous, and now I think the vitrectomy techniques have improved so well that the results of drop nucleus are almost as good as of phacoemulsification.
Dr. Mohan Rajan, are you ready, or Saumil has come back? He has joined.
No problem. I'm ready, sir. I can talk about IOL exchange and haptic braking, sir.
Okay, then can we?
We don't have much time, no?
Okay, sir. ये continue करा लें इनका.
Yes, sir.
Because it's logging.
Yeah, just to show you this IOL exchange, this patient by mistake, instead of 16 diopter, we put 26 diopter, and the Technis lens, you can see is a thick lens. And what I do is when I bring this lens up, and this was done about 1 week after the surgery, and I always inject a viscoelastic, a cohesive viscoelastic, and I put a lens in the bag. So something like an IOL scaffold, what Urbanslal was talking, I put a lens in the bag because I'm a little apprehensive while removing this lens that I will damage the posterior capsule. When you damage the posterior capsule, then the entire battle is completely lost. So then I do the cutting of the lens into 2 pieces, and then try to bring this lens out, and always making sure that there's a good amount of viscoat in the anterior chamber, making sure there's no damage to the endothelium, very, very important. And you can see here, once I cut this lens, I bring it out without any problem, and which is what is called the hand-on-hand technique, and which you can bring it out without any this thing. And this patient did very well. So just to show you that these are the injectors, which is called the medicinal injectors, either the blue or the green ones. And you can see here, this is the Envista lens. What happens is there is a very little space between the cartridge and the silicone, the material there. So what happens is this haptic can get caught like this. Okay, if you try to pull the haptic out, what will happen is the whole haptic, that's what happened here. The haptic got fractured, and I had to remove the lens and put another, extend the incision, remove the lens and put another thing. See, this is another patient. You can see again an injector like the medicinal injector. This is the green injector. Normally, the green injectors are the known for this particular problem. What I'm trying to do is I'm putting an in-focus lens. But again, when I'm trying to withdraw this, you can see that haptic is completely stuck there, and I'm doing what is called a ocular episotomy. This is called the episotomy. This is called the ocular episotomy. I'm using a 11 blade and opening up the cartridge. This is what you have to do. When you open up the cartridge, you create more space between that silicone, this thing, and the cartridge, and you can see how I'm releasing that haptic completely without deforming the haptic, and putting the lens into the bag without any problem. So just to show you, there's another patient. You can see the haptic has broken. This I think it's a single piece SA60 lens or the Alcon lens. You can see here, what I'm trying to do is I got the haptic. The haptic got fractured. Very rare to occur in the SA60 lens, but can happen with anybody. I was just presenting in the OOP session with this thing. Always record all your cases because you do not know when it's going to come. So what I'm doing is I thought I will do I brought it out, I cut halfway through a quarter, and then brought it out, and then injected it with more viscoelastic, making sure that viscoat is probably the way to go. I don't have any financial interest on this particular thing. And then I try to bring it up, and this is again a hand-on-hand technique, and try to pull it with the lens without extending the incision, and brought and injected a fresh foldable lens into the eye. Yes, sir. I'll stop sharing the screen, sir. About the haptic braking, sir. Yes, sir.
Thank you. Saumil, can you come and show your IOL drop?
Out here, I'm talking about these cases of PMMA lens. Now, IOL drops sometimes are seen in older patients where overall the zonular complex has loosened, and many of these patients have these PMMA lenses which we had put many years back. Now one technique which I would just like to show is how do we implant or continue with these PMMA lenses, they were giving good vision just because they have dislocated. Now the patient is having poor vision. Without making any large incisions, how we can manage these cases? This particular case, the IOL was already tried dialing into the sulcus, but it was re-dislocating. So now I am trying to again go ahead, dial the lens in the sulcus, but I'm going to fixate it to the back of the iris. So after injecting intracameral pilocarpine to constrict the pupil, we see the shadows of the haptics, the outline of the haptics. So we pass a 10-0 or 9-0 proline, preferably a 10-0 proline out here, and pass it under eyes and below the haptics of the IOL, and we retrieve the suture above that. So in essence, we are looping the haptic to the iris. Sorry, and then we tie a knot outside, and of course we stretch it so that it slides inside. This is the Seepser's sliding knot. So this knot, essentially what it does is it holds the haptic to the iris, back of the iris. Mind you, this is possible only in cases of a 3-piece or a PMMA lens, not in cases of a single piece IOL. So this process is repeated for the superior haptic. So creating only 2 side ports, we are able to fixate this lens to the back of the iris, giving back good vision to the patient. So then we go ahead with just a OVD removal, and that's as well as that. Right. So this is the first day post-op photographs. You can see that slight ovalization of pupil is there, but overall the lens is very stable. These are the suture knots which are there in the iris. So that's what, without creating any big incisions, we can go ahead with IOL reposition.
Thank you. Thank you, Swamil.
Thank you.
Now we'll invite Dr. Harbans Lal for his way of managing the broken haptic break during the insertion. Again, going to the posterior.
Yeah. This is my technique, which I described long time back.
Yes, yes.
And so this is Mohan Rajan is there.
Yes, yes, I'm here.
Now, Mohan, just watch this video, and the mistake you were doing, may I point out, was that you are not holding the optics properly. You are trying to cut inside the eye. In this case, I bring the one haptic out so that I can stabilize the lens while cutting, and use 2 instruments, one below, one above, and you can pull it out very easily. Otherwise, it will not collapse from the incision very comfortably. Now with this haptic out, you pull it away from the eye so that it is kept tight and stabilized at the incision, then cut it. So now this lens removal is very easy. Just you have got to, whether this cut is in the center or not, it makes no difference. And even if it goes up to the nearly, it must go up to the center, that's it. Once it goes up to the center, then you just have to dial it out. What you need to ensure is that this part of the one part of the haptic is underneath the corneal lip, and another is in the tunnel. So I'm going from the side incision and place one of this underneath the corneal lip. That means between the cornea and the iris, and another one is collapsed into the tunnel, and then you just dial it out, it will come out very comfortably. So you don't have to do anything, you don't have to go inside and pull it out. And when you are taking out the loop, one instrument should be below a rounded posture to guide it outside the incision, and it comes out very easily. And from 3 mm, it can be easily removed, any type of lens. Thank you.
Thank you. Thank you.
I think the most important message is the hand-on-hand technique, sir.
Yeah.
Wherein you have to
The most important is pulling it outside. You have got to do the counter pressure when you're cutting with the scissor.
That is a hand-on-hand technique. That's what.
That is afterwards when you're dialing it out.
Yes, yes.
But otherwise, when you're trying to cut it, if you go inside the eye, you're not holding the lens, then you're slipping. You don't know what way it will go because there is no counter pressure. Absolutely. Once the lens is stabilized in the tunnel and there is a haptic is out, then you're pulling it outside, so the lens is stable and you can cut it very easily. And you can cut with any scissor, whether it's a Warner scissor, corneal scissor. You don't have to worry whether it's 2 mm on the one side, 4 mm on the other side. But it should be beyond the center. That's the only thing what you need.
Yes, sir. For that, your incision should be around 2.8 mm.
3
It is
millimeter.
not possible to have.
But 3 mm is good
Nowadays,
enough. 3
3
mm.
mm.
Now we have
Nowadays-
very little time. Dr. Harbanlal, please stop sharing the screen and then please continue. Please continue.
Yeah, that's all.
That's all.
Because with 2 mm incision, what nowadays we are doing 2 mm, it is not possible with the having haptic and scissor in the same wound.
No, I use 3 millimeter incision.
3 mm.
Yeah, 2.753 is.
Yes.
Okay, so I would like to share my way of managing. I follow Dr. Harbanlal, always a good teacher. So you can see here that the haptic is broken. And when I was trying to pull it out through this injector, I did not do the episiotomy, but then you can see here, it has been released. And then I found out, I noticed that this haptic has been broken here. So I need to take out the lens, but my idea is to take out the lens to the same wound, same size. I don't enlarge the wound so that the wound integrity is maintained as well as the stigmatism is checked a little bit. So here you can see that the rhexis is the haptic is broken. I try to hold the lens to the side port with the intravitreal forceps, and then I try to take out the haptic, as Dr. Harbanlal has rightly said. You have to hold the lens and then release the lens so that there is no catch anywhere, make it free, and then put the V-scope, form the chamber completely, fully. And then the scissor is introduced into the anterior chamber, and the lens is not totally cut into 2 pieces, only halfway or little more than halfway. So that because this lens has to be brought out to the same wound. I don't make 2 pieces. You can watch here, I'm holding the haptic, taking out, see that, this side, again, rotate the lens and try to take out the other part. So the same lens, same wound, the lens is taken out and you can go for the next IOL. So this is my way. I always follow my guru, Harbanlal ji. And before we conclude, I think I have a question. Where is it? Stop sharing. We have a question from Dr. Asmita to Dr. Harbanlal. Can we use ACM after PCR or repeated Wilks count on to stabilize AC, which is better?
Yes. Yeah, ACM can be used. The advantage of ACM is that because you are doing the hypovolumic phacoemulsification, that means you don't want too much of a pressure inside the eye. So if you keep a ACM height, say even 1 feet or 2 feet, 1 feet is good enough, a small height. So if you keep the other bottle height also low when you are doing phacoemulsification, so you will get enough of fluid without increasing the IOP. So all those who are comfortable with the ACM can use that.
Thank you. So we come to the conclusion of our excellent session, and I thank you everybody, all the panelists, the faculties, to have joined me on the virtual dais. We really enjoyed, and thank you very much once again.
The time is there is a time still.
10 minutes to go, sir.
10 minutes is there, sir.
10 minutes is there, sir.
Oh, sure. Go ahead then. We can continue.
Yes, sir. Any more questions from the audience, sir?
There is no audience.
No, the question, sir, Ashok sir, you were asking one question.
Yeah.
From Asmita, that is in the presence of PCR, whether to use ACM or not. Am I right?
Yes.
Yeah.
The presence of PCR, ACM is a must. What I think you should separate the irrigation from the cutter and separate the irrigation from the aspiration. You can use a anterior chamber maintainer, but what is important is to have a bimanual instead of a coaxial. If you have a coaxial wherein the irrigation and aspiration are in the same port, then the PCR tear will increase and more vitreous will start getting hydrated, and you will start pulling more vitreous into the anterior chamber. So once you have a PCR, you come out and shift over to the bimanual technique. You can have an anterior chamber maintainer. The most important take-home message is separating the irrigation from the cutter or separating the irrigation from the aspiration.
Okay, but I think we need to type the answer. Whether I don't know whether Asmita can, she logged in and she can hear.
No, she'll be logged in, sir. She'll be logged in.
I don't know whether she can hear, or otherwise it is mentioned type the answer. Is okay, fine.
We assume that he is attending.
Yes, yes.
Please, any other comments regarding the previous complications, the management? Anybody, someone would like to have?
So one general advice for any complication is actually a deferral of surgery is a very good advice I can give to all the youngsters. That means if you have got a complication, you are not very sure how the things are moving, no harm is done if surgery is redone after 2 weeks. Like suppose if there is a PCR and you are not very sure the integrity of the capsule, after 2 weeks, the capsule will get fibrous. It will be better, easily identifiable, and you'll be able to place the lens into the sulcus far more easily than if you try to put it at that time. So the young doctors, my simple advice is, at least to my resident, whatever stage of the surgery they feel uncomfortable with. That means if the first year PG is feeling uncomfortable, the rhexis has gone out, he will leave the case there. If somebody senior is there, will come and take over. If it is not there, I'll operate second day, third day, fourth day. After 1 week, there is no problem. Yes. So any stage of the surgery where you're not feeling comfortable, even it is true for at our level. I mean, suppose we think the things have gone out of the control, it's better to leave it and do it afterwards than trying to rush through and messing up the surgery. So you should not damage the cornea, you should not enlarge the incision too much, you should not damage the iris, you should not pull onto the vitreous. Believe me, you will be far more comfortable and telling the patient, yeah, I have not done it, this was the problem, we will do it after 2 weeks and you'll be all right. Then messing up the surgery and then waiting for 4 weeks, 5 weeks, 6 weeks, the cornea to clear up, and you are not, so iris getting fixed and dilated because if there is so much of vitreous messed up, iris is not mobile. So after some time when the VR surgeon comes over there, he finds the iris is totally atrophied. So better is to leave it and take the help of somebody else if you feel you are not comfortable.
Sir, do you cover this point in your counseling? That at times, suppose you feel that there may be some problem, so do you cover in counseling?
Yes, sir.
Okay.
No. You know, in the consent form we mentioned, sir, the complications.
But when the patient expectations are very high, and particularly when they are paying, no,
counseling, especially for posterior polar cataracts and pseudo in all those patients, tell them.
Yeah.
In any complicated situation, sir, it's better to have all these points verbally and written explained to the patient.
Yeah. Very good.
Not routinely.
I fully endorse Adban Shlal, and because I think it's very important. Many times we have seen him put the lens and next day it's on the macula. So we do not know. Yeah. Because the adrenaline is flowing, you don't have the mindset to think. And everything, your hands are shivering at that time when you have a nucleus drop. I had my nucleus drop after 4,000 cases. So normal tendency for everybody is to go and chase the nucleus and end up in a giant retinal tear. Don't do that, for heaven's sake. Another thing is, when you have a PC tear and we want to put the lens in the sulcus, many times the PC tear, what happens is because of so much of manipulation, so much of prostaglandins are released in the eye, the pupil becomes small. So for heaven's sake, again, put iris hooks. If you are on topical anesthesia, just make the patient comfortable. You are also comfortable. Give a subtenon, give a parabulbar anesthesia, and if the patient is very comfortable, no pain at all, because otherwise the patient will keep straining, and the vitreous pressure again will go up, and the iris will start coming up, and you will become more jittery, and all the complications can occur. So what will happen is, what I'm trying to say is, when you have a PC tear, stay calm, as you rightly said, have a glass of water, and then come back.
No, I agree with you.
Yes, sir. And then put iris hooks and see where your sulcus is exactly. Where is the sulcus is exactly before you put a lens. If the pupil becomes small, most of the times the pupil becomes small, I do not know, and you put the lens as you know, on the table it may be the center, but next day it will be lying on the retina. Yes. So this is a very important message I want to give. So better to postpone the surgery after 2 weeks. Fibrous capsule is there. You can have a good placement. Then you can choose better also. You can think better. You can plan better.
But sir, one question. Suppose you have a vitreoretinal surgeon facility and the whole setup. Still, you would like to postpone the surgery?
No. In my this thing, I'm not telling you. I'm talking about a general ophthalmologist who doesn't do. See, See, this all these conferences are meant for general ophthalmologists and who are, where very practical take-home message is very important. I have a VR surgeon. I myself a VR surgeon. I can go in and pick up any any nucleus drop and do it in the same sitting. I do a glued IOL, I do an iris claw, I put a lens in the sulcus, I do an optic capture, I can do whatever I want. But just because you are doing this, it doesn't mean that that is correct. What is important is 80 to 90% of the ophthalmologists should be able to do what you are doing. So, that is what I think it may.
Ideally, it is to do at the same sitting or wait for 2-3 days, because the second day, third day, you might have some corneal edema. So once it subsides, so your visibility improves. Either you have the retinovital person with you or you are doing yourself, do at the same sitting. Otherwise, you wait for 2-3 days till the cornea stabilizes.
Yes.
You can do after 2-3 weeks. What is the hurry?
2-3 weeks, sir. 2-3 weeks will be better.
Once you have the clear cornea.
See, if the things start messing up.
Well, doctors, I'm so sorry to interrupt, but we need to come up within the next 3 minutes.
We are waiting for your command.
Yes, sir.
Just few questions.
3 minutes.
Doctor,
There are two more questions from the audience.
Yes, we can of course take that.
Addressed to Dr. Rajiv Chaudhary, sir. How long do you wait for IOL exchange? And one is a general question that do you have to exchange the IOL whenever there is a haptic breakage, or can you leave it?
Definitely haptic breakage. Once you have seen in that small haptic breakage, you feel that the lens will be stable, you can leave it. Otherwise, you have to exchange it. And as far as IOL exchange, depending on what condition for you are exchanging it. Suppose haptic breakage, you have to remove it. It is dislocated or subluxated IOL, you have to remove as far as possible. And for refractive exchange, suppose you have put the wrong power IOL or something like, you may wait for 2-3 months so cornea and refraction stabilizes. For toric IOL, you should rotate or change it as early as possible, so to avoid the fibrosis.
Yes. And the next question, please answer.
Already answered.
Already answered, sir.
Always exchange when there is a haptic breakage or any damage to the IOL. Please go ahead and exchange.
This can become a medical legal problem, Somil. And if the haptic breakage is there and the patient goes somewhere else, and definitely it is going to become a medical legal problem. So, whenever there is a fracture,
if it is a very small breakage and your lens is stable, it is not visible.
Difficult sometimes.
In general, sir, I would propose for exchanging whenever there is any damage to the lens optic or haptic part.
See, I had a patient, Somil. I had a patient wherein my staff, as an OT assistant, caught with the center of with the McPherson forceps, made a mark in the center, okay, in the center of the optic, and I left it like that. Okay, it was producing a lot of problems to the patient because there was something like a crack. It was not actually a crack, but it was a mark right in the visual axis.
Definitely, it is in the optic.
Producing polyopsia and glare and all that. The patient sued me. So I think it is important that whenever you see a damage, and another important thing which I just mentioned in the OOP session is that whenever you have resistance while putting the lens, when you are finding it tough to put the lens inside in the cartridge, please don't use that lens. Please come out and probably exchange that lens or take another injector. Or most of the time this can happen with the preloaded lenses. You have to be a little careful about it because you can end up fracture of the optic.
And with you on this, we need to exchange.
Before I conclude, a request to Dr. Harbanslal. Suppose with these same courses accepted next year, please come out with the management of drop IOL and the drop lens.
Okay. Thank you.
Thank you, sir.
Everybody, thank you.
Thank you.
Sir, I'll bring dropped IOL, sir, but don't drop me, sir.
Thank you so much, doctors, for summing it up on time. We are dot on time. It's 11:55 and the whole credit goes to the panel.
Yes, go ahead. Thank you.